as Nicole indicated, we have a very full agenda, so I'm going to even save these introductions and make them as short as possible. Our topic today is one of my favorites, which is rural population information initiatives in general. So as we move into value-based payment, as we strive to improve our care, et cetera, it's going to be incredibly important that we have really good information databases, that we manage those databases effectively, and then that we act upon the data and the information as well. If we don't have those information bases, I'm just a little skeptical that we're going to make the kind of progress that we need to moving forward. Besides our usual updates, we're going to look at the topic itself. We have David Mark here. And David is somebody that we've been working with the center for some time. He's with the College of St. Scholastica. He's an associate professor. He's the department chair, and he's a health informatics graduate program director in health informatics and information management department. He helped to put the center population health portal in place. We thought he'd be a perfect person to kind of provide that initial overview. We have Kwang No, and we also have Leanne Dudley here from the Texas Organization of Rural Community Hospitals. They work in partnership with our Texas Flex program. So they're going to be talking about what's just a really pretty exciting database and information base that they have developed in Texas. And then finally, Melissa Bosworth is here, and she's with the Eastern Plains Network. She's the executive director of the Eastern Plains Healthcare Consortium. She was with the Colorado Rural Health Center, et cetera. Forgive me for not going into more detail about any of these speakers, but I think you're going to find just a wealth of knowledge in the next 60 minutes. So kind of with that, I'm going to, Nicole, do you want to say anything about our TASC update, or should we,
I'm going to actually glaze right over TASC updates too and turn it over to Laura Seifert from the Federal Office of Rural Health Policy for FORHP updates.
Yeah.
Thank you so much, Nicole, and thank you, everyone. As far as our Flex updates are concerned, they're going to be very quick for today. And the real update is that I am your new Flex program coordinator. Tori Leach has accepted a new position over in the Bureau of Health Workforce. And while we are very sorry to see her go, I will be taking over. So if anyone has questions, comments, concerns, ideas, please send me an email. I'm open to any and all information on the Flex program. And I'm going to kick it over to Jenna for our Office for the Advancement of Telehealth updates.
Thank you, Laura. Good afternoon, everyone. I will also make my comments very brief due to the full agenda, but we do have, just for awareness, we have quite a few telehealth resource center conferences that are coming up. The two most immediate ones are the Mid-Atlantic Telehealth Resource Center. They are having their Matrix meeting on April 24th through the 26th, and then the Great Plains TRC meeting will be May 23rd through the 25th. We also have a new list of podcast resources that are within our telehealth National Consortium of Telehealth Resource Centers. So I will drop that in the chat as well in case anyone is interested. I think that is all I have for today. Thank you.
Yeah, thank you very much, Jenna. And finally, but not the least of all, we're going to get a brief update from who's next on the agenda. Oh,
we're going to start with David.
Oh, what about Neil? Neil, I think you're next,
right.
aren't you? Neil, good. Sorry, didn't mean to.
Thank you, Terry. I'll keep this extremely brief. So here's a little bit of a Washington report in under 2 minutes, I promise. The $1.5 trillion omnibus appropriations bill grants a 5-month extension to the telehealth flexibilities that were created during the pandemic and would leave those flexibilities in place for 151 days after the end of the federal public health emergency, which is on or about, I think it's April 18th. for now and expected to be extended possibly into July. The bill would, as you know, continue provisions that allow Medicare recipients coverage to be billed for telehealth visits, including some audio-only visits, regardless of where the patient lives relative to the healthcare provider. And additionally, the bill would postpone a requirement that older adults who seek virtual mental health care have an in-person visit within 6 months of telehealth, of their telehealth visit. In terms of other digital health policy moves, the IRS is considering language that would include wearables and associated software as an eligible tax advantage FSA and HSA expenditure. So that remains to be seen whether that goes forward or not. On the privacy and security front, I just want to remind everybody that there is a great deal of concern about InfoSec, given the Ukraine situation and the possibility for cyber attacks. And healthcare needs to be especially vigilant about this. In fact, HHS has a website to talk about Ukraine cyber conflicts and the possibility for it to bleed over into the healthcare sector. On the broadband front, the Infrastructure Investment and Jobs Act creates, as you'll recall, $48 billion for 5 new programs for NTIA to administer over a period of years. And that's in process right now. And the FCC is seeking public input on digital redlining, ensuring that equal access to broadband is available and doesn't include any digital discrimination based on income level, race, ethnicity, color, religion, or national origin. And then finally, I would just say, and thanks to Denny for bringing this to our attention, there's bipartisan legislation called the Telehealth Benefit Expansion for Workers Act that would amend HIPAA and the Affordable Care Act to allow employers to offer standalone telehealth service programs, not unlike dental and vision plans, in addition to existing health insurance plans. And there's 5-6 members, Representatives Delbane of Washington, Jackie Worlowski of Indiana, and several others. And we can get you additional information on that also. I'll turn it back to Terry, I think. Thank you.
Yeah, thanks, Neil. There is a lot going on. Obviously, here's some, but yeah, if there's anything else that we need to share, and from a policy standpoint, we'll just make it a point of getting it out to you, or if we can put it into the chat, however that works. So without any further delay, I'm going to turn things over to David Mark, who's going to provide us some background on the topic. David?
Great. Thank you, Terry. And thank you, everyone, for having me today. I'm going to share my screen. I have some slides I'd like to share. Okay. All right. So again, my name is David Mark. I'm from the College of St. Scholastic, and I've had an opportunity to work closely on this topic related to population health, particularly as it relates to, to rural populations. So I'm really going to be addressing predominantly these top 2 objectives that you see on the screen here. I want to share with you some data sources that you can utilize to, explore population health and, what we mean by population health and how to understand the health of the population. But then we're going to take a step further, and I'm actually going to show you an example. So I've had an opportunity to work on a project with the National Rural Health Resource Center to develop a population health toolkit. And I'm going to provide with you today an example on how that data could be utilized to make some informed decisions related to addressing, healthcare concerns in a rural population. So just to begin, I want to provide background information. You probably have heard often, when we talk about population health, that there's a lot of data that's out there. Go and find it. It's you're just go out there. It's there, but it's a little more difficult than just saying there's a directive. There's all this data. Go find it. And really this started because of this thing called the internet. It created a data revolution. There's a lot of stuff out there. There's a lot of data. Storage is cheap. And a lot of people have access to the internet. And just think about your own role in sharing data. You know, we utilize email where we're sharing a lot of information and data that way. Online storage like Google Drive, for instance, or social media where we're sharing pictures and video or a narrative. Streaming platforms, there's you know, of how we're viewing content. Journals and libraries are online. Online shopping, reviews of products, all of these are data sources, and it's all driven by providing accessibility to those data sources through the internet. So it goes beyond just that type of data though, right? Where you talk about data as, when we think about it traditionally, we think of, you know, a spreadsheet. We've got rows and columns of data, and that's how we can access data to better understand, for instance, the health of the population. Well, the idea of sharing all of this data online has been due to a number of reasons, transparency being one of them. The United States, as a federal government, has adopted an approach of like an open government approach to sharing data, and where important data sets are being published online to engage citizens to have awareness and to have information at their fingertips to utilize to make informed decisions, or to be advocates for policy, or just to, you know, be informed of what's happening in the government. So transparency is one reason why data is being made available. Another is public service improvement. By offering citizens raw materials, such as data, to understand, you know, the current status of around many different topics. The idea is this can help engage the citizens within their communities to improve public services, just like we're doing here today. Innovation and economic value as well. There's been a lot of technologies that have been developed because data is available online, and this has led to a lot of services and data-driven products. And this helps us to better understand our potential market and customers, like rural, you know, in rural healthcare, who are the patients, the consumers of the healthcare. And then also efficiency. By making the data available online, it's less costly to discover and access that data. That could probably be argued at that point though. So I just want to share with you some data sources of where can you go to access population level data. To begin, I do want to share just a definition. So there's public data and then there's open data, and it's worth defining the differences between those two. So public data is data that's freely available on the internet, but it may not be readily accessible. What I mean is there is data that's out there that you can access, but to pull it down from the internet and make it usable in a format that can allow you to maybe analyze that data, that could be difficult. So there may have some restrictions on the use and require permissions as well. An example would be, think about social media, where there's a lot of data out there on, you know, Twitter, on Facebook, on many other social media websites. But to actually utilize the data that's on that, it's a very rich data source, but it would require permissions to be able to actually access and utilize that information. Open data, on the other hand, is data that's freely available and can be readily accessed, used, reused, and redistributed. So this is data that's often managed by government agencies, but not all the time. I'll show you some examples. There are typically no restrictions on use, so you can use this data however you want. However, the format does tend to be more structured and usable, but that's not always the case. Sometimes it can be like .dat files. They're a pain to work with, but most of the time you can get data in like an Excel format or a CSV format. Some examples of places, websites where you can get open data is like data.gov or data.cms.gov. So public data, it can be open, but that isn't always the case. So just understand there might be a distinction between public and open data. So where can you go to get data? Well, the first place are data repositories. These would be websites that you can go to that have a collection of data sets. So one example is data.gov. Data.gov is a website that was developed as part of the Open Government Initiative that was signed into law in, like, I don't know, I think it was like 2019 during the Obama administration. And that resulted in federal agencies having to publish important data sets online. And they had to, the goal was to have federal agencies publish at least 2 important data sets online every year. The result was some community sites as well, one being healthdata.gov, which is a community site of data.gov that publishes health-related data sets. So that's another rich site that has a lot of different data sources that can be utilized. Google Dataset Search is another website that was designed by Google that is specifically for data sets. Now, one thing about this is you could get access to data that's not in a very user-friendly format. It's not always public data. It could, it's not always open data. It could be publicly available, but not open. But there is a lot of data sets that you can find and retrieve using the Google Dataset Search as well. So if you're interested in finding data on a topic of interest, any 3 of those sites that are listed there would be origins or places you can go to try to find data on a topic of interest. Another is CMS Data Navigator. This is where you can begin to find data that would be managed and published by CMS. There's a lot of data that's out there. There are all the like a lot of individual data sets, like the compare websites that exist, which I'll talk about in a moment. It can be found on CMS Data Navigator, but a lot of the other data sets that CMS publishes can be found there as well. CDC Wonder is a great place to go to get some information about disease incidents. They have a lot of great information and data that we actually utilize from all of these websites in the population health portal I'll be presenting here shortly. But if you're interested in finding like COVID-19 data or maybe data on diabetes or heart disease, CDC Wonder would be a great place to go to as well. Some others that you might be less familiar with include AWS Data Exchange. This is designed and managed by Amazon Web Service, and it allows you to use an API, so programmatically accessing data that is shared using this data exchange portal. And it is where data publishers allow parties to basically share data through this data exchange and just provide access to anyone that wants to subscribe to this AWS data exchange. So you can publish data and exchange it for others to access and use. In exploring the AWS data exchange, it's a great tool, but it's somewhat limited currently in terms of the healthcare related data that's available. Kaggle is another website that is actually the purpose of Kaggle is to sponsor data analytics competitions where you can actually analyze data and there's like awards and prizes to the person that creates the best model or the group that creates the best model, which is fun and awesome. But they also have a lot of data that's accessible through Kaggle on a lot of healthcare, important healthcare topics. That data tends to be go through a cleansing process. You get a lot of information on it. Some of it's outdated, but it can be a really interesting site to go to explore different topics that might be of relevance to a population of interest in your area. GitHub, GitHub is another example. It's a forum that was designed where developers can share software and code with other developers. However, a lot of the forums that you can access, there's a lot of data that's available through through various developers as well. A lot of the COVID-19 dashboards that you see out there are shared in the raw source code is shared on GitHub, and actually the raw data is shared there as well. So it's worth exploring that as an option. And the last one is the Harvard Dataverse. This offers more than like 140,000 data sets related to a number of different research fields, and a lot are healthcare related fields, where researchers can opt to share, archive, access, and explore research data sets. So it's a voluntary project for researchers to collaborate and share data. And it's another interesting source that you can explore. And these are a few. There are many, many others that you can explore. So those are examples of data repositories, right? So a good place to start is healthdata.gov, in my opinion. You start there, see if you can find some data on a topic using some keywords to explore what data you can retrieve. But let's say you want something specific, and there are a lot of standalone data sets that are websites you can go to that have data on that's sponsored by a healthcare organization or entity, oftentimes a federal office or agency that publishes data and makes it available to the public for use. IPOOMS is one such data set. It provides census and survey data from around the world, actually, and integrates it in one single website. So one particular data set that I like to use, it's the integrated health inventory series data, that it includes individual level, so like person level data on a number of health related survey questions. So you can even get information on how individuals and households are utilizing the internet to find health information online. So there's a lot of interesting data there, but the IPOOMS data, it may require you to have some like knowledge and understanding of how to utilize and analyze some of these data sets. So if you have that analytical prowess to be able to utilize some of that data, it's a really rich source of information. The county health rankings data set is incredibly informative to get county level data on many interesting and relevant topics related to population health. And it's a great place to go to get information about your particular area and to just evaluate it. It's got a really nice dashboard on the website, but you can also download the raw data itself to utilize for your own purposes. The compare websites, this would be something like Hospital Compare, Home Health Compare, there's a Provider Compare, there's Nursing Home Compare on the compare websites. It's a really great source of information to get outcomes related to healthcare entities like hospitals, and be able to see, you can get patient satisfaction survey information. You can get information on readmissions, on mortality specific for hospitals. The Dartmouth Atlas data set, that is a data set that includes, a lot of information related to payment, Medicare beneficiary information, for instance, that would provide you with county level data as well. CDC Places, this is one specific data set that includes information on, some of the major leading causes of death as well as disease in the United States, and provides county level incidence of, the percent of the population with diabetes, for instance. So this is a really great data set to get some of that county level data. Some of that data is also found in the county health rankings data set as well. Then there's the CMS payment data, PUF, that stands for public use file. This includes some information on payment data. It includes inpatient, outpatient, Part D drug, durable medical equipment, hospice, and it aggregates data on the provider level, the location. And if you're looking at some of the drug data, it looks at drug or brand name. It also segments data by HCPCS or CPT codes, or for the inpatient data and MSD or G codes. So it's a limited data set, but it does provide a lot of information about some of the more common reasons for inpatient, outpatient visits and the more common drugs that are being prescribed. Then there's license data. This is data that you can utilize but it may require payment to access and use, or it may require like some agreement to be signed, or you have to undergo some like specific training to be able to utilize the data. HCUP is one example, the Healthcare Cost and Utilization Project. It has reports and data that, that is free on the website, that you can get some of their aggregate data. But if you want the raw data itself, it does require you to sign a data use agreement, do some user training, and there is a payment that's required. But the data does include information on inpatient, emergency department, and ambulatory visits. It also has information on children as well. And it focuses on healthcare utilization, on the access to healthcare services, the quality as well as outcomes. OPPS is the Outpatient Prospective Payment System claims data. It provides specific information on outpatient payment data, such as diagnoses, for the major claims related data. That includes information on the major diagnoses, provider information of who's providing the services, the procedures that are being provided, and cost of a visit. And it's all included in that specific data set. And there is the Healthcare Cost Institute, which offers claims data for medical and pharmacy encounters. This is a huge data set. It has over 55 million records for commercially insured data from commercially insured data, as well as over 40 million Medicare insured individuals. So it's a very large data set that aggregates the data to be intended for uses for research purposes, policy making, for providers and for employers to have a data set to utilize. And then just a couple others very quickly is the NCQA offers a data set on health plans. This includes some of the HEDIS and CAPS performance measure data. So it does include a lot of information on health plans as well, and some of the performance measures that are reported out for the various health plans, as well as CAPS, which would include some of the patient experience measures for inpatient and outpatient services. And then the last one is the N2C2 NLP research data sets. This is for natural language processing. This is where you can get access to actually like clinical notes for the purposes of like research and education. It does require a data use agreement to be signed, and you can get access to fully de-identified clinical notes, which if you are on an initiative where you're trying to create innovative approaches with free text, this is an option to utilize. Okay, some other, all those data sets are great, right? And they're out there, they're ready to be used. But one thing that can be difficult is actually making sense of that data that's available online. So I worked on a project with the National Rural Health Resource Center to create a tool that can be utilized by you and others to really build awareness around rural population health and to inform stakeholders on how you can utilize this data. And then you can even act upon it. We update this data on an annual basis. So it's very, it's up-to-date data that's out there, that's available from some of these websites we talked about, and it's scenario-based. So it provides you information about a specific scenario, and you can, drill into that data to look at what's a topic that might be relevant for your specific populations. And then you can create some, decisions based off the data that's available. So what I want to do is I want to show you a use case. So now that I presented to you some, data sets that are available for use, I want to provide with you an example of how you can utilize this population health portal, which aggregates and takes a lot of those data sets into one website, and how you can utilize that website for purposes of exploring a population health topic. So what we're going to look at as an example is COPD. And we're going to explore, how COPD rates by county in 2 different states, how that might relate to uninsured rates in rural America. So here's the link I'm going to go to here in a second. but we're going to compare COPD and insurance rates in rural and metropolitan Minnesota, and also look at Louisiana as well as a comparison of. So, I'm located in Minnesota. Let's see how Minnesota compares against Louisiana. And then we're going to develop an interpretation of that data. And then we're going to establish an actionable step to address the observed problem. So it's time for a demonstration. So what I'm going to do is I'm going to go to that link that I have in the prior slide. And where that'll bring you is to this website that you can see on this screen. So over on the right-hand side, we have a number of different scenarios. The way the population health toolkit is created, you have a lot of different scenarios that you can work through to get information about, health-related topics of interest. The COPD risk factors and rurality is the topic that we're going to be looking at. And here you can see just some background information about the topic, and then you can analyze the data. And what we've done is we've actually created a dashboard for you to interact with to utilize that data. So you don't have to go through the steps of actually analyzing it. But let's say you did want to actually get the raw data, you can click this text-based table format to get the raw data for your own purposes, if you want to download it and do what you want with it outside of the portal. I'm going to just put this in this desktop layout to make it a little easier to read. And then I'm going to open it up in a wide full screen mode. So if I wanted to take a look at this data and choose Minnesota first off, to just explore kind of the trends we're seeing in terms of COPD and related to a number of other factors. You can see in this dashboard I have the CBSA classification, that is core-based statistical area, and you can select if you want to look at all the different geographic locations or just look at metropolitan, micropolitan, or rural. And then it shows the COPD rates for each of the various counties, and then being able to, this isn't clear cut, but some of the counties, are in more metropolitan, some more micropolitan, and some more rural. You can then segment that out further. You can see Monoman County, which is predominantly rural, has a COPD rate of 8.1% in Minnesota, which is the highest in the state of Minnesota. Now, looking at these graphs on the bottom, you can see the relationship of the rate of COPD by obesity, and what each of these dots represents is a county in Minnesota. So looking at this, you see there is this line, it's going upwards. This is showing a scatter plot. That's showing that there is a positive relationship between COPD rates and obesity rates for Minnesota counties. And this blue line, which represents metropolitan, having a much stronger relationship. You can see something similar for COPD rates versus smoking rates in counties in Minnesota. And then if you look at COPD rates versus uninsured, what you can see are that this line is increasing as well. So as the percent of the population, for counties that have a higher percent of the population that is uninsured, we tend to see a higher percent of the population having a higher COPD rate for those counties. And then the last one is looking at the percent of the population that is designated as white versus the rate of COPD. And you see some different trends here as well. So just looking specifically at rural Minnesota, looking at this topic of related to uninsured rates, overall, if you kind of look at where the middle of these points are for uninsured, it's around 7% or so of the population is considered to be uninsured. And as in the counties that have a higher uninsured rate, there tends to be a positive relationship with the COPD rate. That means as the uninsured rate increases, so does the COPD rate. If I hover on that line, you get some statistics. You get the equation of that line as well as the R-squared value. The higher that R-squared value is, the stronger the relationship. And so we are seeing, a moderately strong relationship between uninsured rates and COPD rates. Now, if we compare this to Louisiana, what we see here is we see something different, right? We see that for the uninsured rates, we actually have it going downward. So this is showing a negative trend. But if you look at that R-squared number and that p-value, what that is showing is that relationship, it's not very strong, and also that that p-value should be low. It should be less than 0.05. If it's less than 0.05, that indicates significance. Given that this p-value is not very low, this shows that there isn't a significant relationship between uninsured rates and COPD rates. However, looking at the uninsured rates in rural Louisiana, we see that that uninsured rate is quite high overall in Louisiana. If we add in all the CVSAs here, you can see compared to the metropolitan and micropolitan areas in Louisiana, those more urban settings have a strong positive association. However, in the rural settings, there isn't a significant relationship. In fact, there tends to be a much higher percent of the population that's uninsured. So what do we see here? Just very quickly, what did we see in this trend with the comparison of Louisiana and Minnesota, with looking at COPD rates and uninsured rates? So Minnesota, COPD rates, they were higher in rural counties compared to urban counties. There was a moderately strong positive correlation with uninsured rates and COPD rates in rural counties. And the average, on average, the COPD rate in rural counties was about just over 5%, while the uninsured rate was about 7%. In Louisiana, the COPD rates were higher in rural counties compared to urban counties, but there wasn't a significant relationship. And on average, the COPD rates in rural counties was over 10%, with uninsured rates about 10%. So you're seeing that there's a significantly, greater percent of the population with COPD and that are uninsured in Louisiana when comparing that to Minnesota. So overall in Louisiana, uninsured and CPTO rates were high. In rural Minnesota, the COPD rates were highest in counties with a higher uninsured rate. Rural counties with a higher uninsured rate are more likely to have high COPD rates. So why is that? Why are we experiencing, why are we seeing such a trend? Well, what I did is anytime I find a finding, you have to create an interpretation to this. And where I tend to go is let's go and find literature. Let's go and see what the, going to like Google Scholar, a tool like that, see what others have found. Well, other studies, and this Gaffner that has published this article in 2022, they're kind of publish a lot of information about rurality and COPD. And what they found are that rural residents with COPD, they tend to be poorer, had less education, they had worse health, and more disabilities. And they observed a large access disparity by race and ethnicity and income in individuals both in urban and rural counties, with the highest rates of foregone care among minorities in rural counties. So those counties that had a higher percent of the population with minorities tended to have higher rates of COPD. And this is backed up with other studies that have found providers in rural areas were satisfied with their ability to treat symptoms, but they're unhappy with their access to specialty care services. So very quickly, if you look back and you recall in terms of the COPD rates and how that relates to a factor of race in Louisiana and in Minnesota, you can see that in Louisiana, the percent in rural areas, the percent of the population with COPD, there's a very strong negative association with the percent of the population that is white for these various counties. So there's likely a racial divide in terms of the services being provided in the counties in Louisiana, the racial divide, and the potentially how that might relate to access to care as well. Versus in Minnesota, you see actually something very similar. So when you are looking at the counties that have the highest rate of COPD in Minnesota counties, they tend to have a lower percentage of the population that are identified as white. So this would validate what some of that prior research had shown with a potential disparity in health related to race and ethnicity in various counties in Minnesota and Louisiana. So what action can be made from this? So now that we saw some of this data, we see that there's potentially certain counties that are experiencing challenges with COPD and and rurality in various areas? Well, we could advocate for public change and access to care and services for specific populations. You can also create pathways for care for specific populations through remote monitoring, potentially. Integrating care with remote monitoring, there's studies that have shown that this could actually lead to better outcomes, particularly in rural areas. So remote care, telehealth, there's pathways for providing care in these rural areas that could be addressed and advocated for. So in conclusion, I know I did this very quickly, but data is readily available to understand and address population health in rural America, but you got to take the time to be able to understand and utilize that data to take action. I recommend checking out that population health toolkit tool to see if you can make sense of certain health related topics in your area and maybe some decisions that you can make using that information. So public change, it really begins with information that derives from data, and really it's the data's in your hands to do with it what you will. I provide a link to all the data sources included in this, and also here's some of the citations, and feel free to contact me if ever you have any questions or want to talk about this further. So with that, I will pass it back to
You can pass it back to me, David.
Okay,
so,
Terry, go ahead.
So I can thank you. And also, if you come on into this tool on the center's website and you have questions, do send them to Nicole or I or anybody else at TASC, and we'll probably reach out then to David to get an interpretation, or you can go directly to David as well. So thank you very much. We have two other speakers, and I'm just going to say I want to make sure that they've got some time. They have adequate time here. So we may run over a little bit. So if you can stay with us, that'd be great. Our next speakers are Kwang No and Leanne Dudley, and they're going to talk about a really pretty remarkable database and information center that they've developed in Texas. Kwang, are you going to begin?
Yeah, thanks, Terry. Thanks, everyone, for the invite today. We're light intentionally on the slides because I want to jump into the data hub and show you some of the things that we've been working with. In the next 10 or 15 minutes, just want to share three quick things. A little bit about our data roadmap. We've been intentional in our work with the Flex program here in Texas, and then jump into the hub and show you a little bit about some of the tools and resources we've developed for our hospitals. And then talked a little bit about how we're beginning to mine data sets for improvement services, targeted growth improvement, and for things like population health management. Earlier I mentioned that I was on the road and actually had to stop at a hospital outside of Dallas to join the call. We're actually visiting with United Health on a value-based initiative and how we can use data to help support some of the population health management initiatives. So go ahead and go to the next slide, Leanne.
Hang on, sorry. It's gone. Kwang. Kwang, are you there?
Sorry, somehow I mute myself. We launched a data program December 2020 during the peak of the pandemic. And since then to now, we've actually launched 85 hospitals. And within a week, actually, that number will be about 115 critical access and PPS hospital. We work with 25 rural health clinics last year launching their sites. We're about to launch sites for another 25. So we'll have 50 clinics on the data program. Over 160 user, 145 million records and ongoing, adding every quarter, and then built a bunch of different tools and resources for our hospital. Next slide. I want to show you a quick representation of our data roadmap. There's a rationale and hierarchy in how we think through the data process. And this is informed by our work in the financial and operational improvement project with our Flex program. Over the years, although David mentioned a plethora of data resources out there, for a variety of reasons, our hospitals have not had access to data in meaningful ways. And so we aspire to build something from the grounds up specific to some of their needs. And so we begin with defining the service area. And that's not necessarily just the county area or the county line, but truly understand your opportunities for growth, primary, secondary, service area. So understanding what your sandbox is, how big it is, who's playing in it with you. And then next, we need to understand, the two sides of the coin. One is how much of that population and market share do you capture? That's your market share. And how much do you not capture? That's your out-migration. And by the way, Leanne will get into the hub and show you that from an out-migration standpoint, we can see where every cases are going all the way to the specific doorsteps. And then combining CMS financial data, we're also able to show a hospital what the profit, what the financial implications are for the market that they capture and for the things that they don't capture. By the way, the main data set that we're using is all payers claim. Here in Texas, we call it THCIC, but it's all payers claim. And so combined with CMS financial data, we're able to understand, the financial impact of the business itself. And so now we're in the phase where we're looking at specific use cases for the data, and I'll show you a small sampling of what's been happening with the data sets so far, but we're looking at how we can build a strategic planning framework, utilizing the data, integrated to the data, so that's it's a living initiative and a document. We're also moving toward how we can incorporate contract rates, because obviously understanding that much of the cost is tied up in contracts, that's an important piece. And then ultimately tie up to, a vulnerability or strength success index that shows, how close to the cliff are you? Are you doing well? Are you, about to fall through the cracks? And so that's sort of our general data roadmap. Next slide. Our work begins with data, but our aim and what we target is improvement and growth. And here's a small sampling of some of the use cases that we've been able to see in the last year and a half. Anything from strategic planning to onboarding of new CEO and executive team to, pricing strategy, replacement analysis, service expansion, market expansion. Interestingly, we're actually in the process of helping hospitals recruit physicians, utilizing some of the data, analyzing the market, looking at what the potential, volume is, and things like that to be able to help that hospital recruit a general surgeon. So just a small sample again of some of the specific uses that our hospital are engaged in through the data program. That's hopefully will provide you with a context of what we're doing. I'm going to go ahead and turn it over to Leanne as she logs into the hub and show you a real quick overview of some of the tools that we've developed.
Thank you, Kwong, and thanks for the brief overview there. So I'm pulling up here on my screen the Torch Hub for Analytics site. We do have a public-facing component to this site, but we also have private-facing pages for each one of the hospitals and the rural health clinics that we work with. So if you want to follow along, or if afterwards you want to go out to hub.torchnet.org, I will put that in the chat box. You're welcome to take a look at some of the work that we have. We do have some national information like Medicare Advantage. This is all GIS and ESRI based. So a lot of the stuff that we do is map centric. We also have dashboards and things like that. Kwong mentioned that we added in the rural health clinic information last year. This was a new area for us as well in terms of being able to glean the data. We appreciate David's presentation on all the data sets that are out there. We're very familiar with a lot of those and work with them on a routine basis. Again, if you want to go out there, also in the public facing pages, we partnered up along with the State Office of Rural Health here in Texas and Torch with the Texas Association for Rural Health Clinics. And I know that we ended up pulling together a lot of the information from a number of different sites. So if you kind of want that one-stop shop for rural health clinic toolkits, you're more than welcome to go out and look at some of the work that we've got or pull information from there. So just very quickly here, as Kwong mentioned, we have stood up sites for, at the end of this week, will be 115 hospitals. We have a very small team here. There are two of us. We really appreciate partnering with Torch. So 2 people working for 115 hospitals and rural health clinics is a pretty heavy lift. in terms of our data. But once the hospital is logged into their own site, you can see they can get to market share information, and they can look at out-migration dashboards. We have an interactive video if they forget how things work. We have profitability dashboards. We can also put other partner information on the website. So this is from a colleague of ours who did a lot of charge master review as one of the Flex monitoring program initiatives that we had last year. And then some of you probably recognize the Flex monitoring F&O dashboard, the financial and operational dashboard. This was one of the first things that Torch asked us to recreate, to pull in those 22 metrics. Our data is from 31st, 2021. It's very current. And we recreated all of those metrics, but we also did this on a national level, not only for critical access hospitals, but for PPS as well, because we have a lot of small rural PPS hospitals. So you can see the metric for the hospital here. We pulled in what schedule and what line from the cost report that they can look at. In addition, we built Texas specific benchmarks here for rural, micropolitan, and metropolitan areas. So they can click on and off. They can also download this document. I'm just going to show one of these dashboards as a flavor so that you can kind of get a sense of what we're doing here. This is the out-migration dashboard. And you can tell we focus a lot here on outpatient. Kwong mentioned we have very good data here in the state of Texas. They not only collect hospital-based ambulatory surgery and outpatient, but also freestanding, as well as freestanding 24/7 ED. Which we've seen a huge rise in that the procedures or the visits to 24/7 EDs in the last year because of COVID. So really quickly, we can see imaging procedures, surgical. So as we talk about out-migration with our hospitals, we can see patients that are leaving the market. Now, the hospital here can pick, whatever time period they would like, and all of our metrics will change. We also have, we've read through the data. A lot of these hospitals are not full service, so they can focus on only the things that their hospital provides. They can look by CBSA, where the patients are going, hospital system, individual facilities so that they know where that's going. We also have it down into what are called CCS codes. These are common procedure codes kind of rolled together, so we don't have to deal with those 18,000 HCPCS codes. So mammography. So very quickly, our CEOs and executive teams can say, gee, I may have an opportunity here in mammography. So that's just an example of some of our dashboarding capabilities. We also stood up data around population, and we pulled in cost report metrics for rural health clinics. So that forms kind of some new information that we can bring to the table. So for our presentation today, because this is population health, I have put together here, if I can find it, hang on just a second. Okay, so I have put together one of the tools that we have available. So David talked about all the different data and the disparate data and having to clean data and all the things that you have to do to data in order to make it really resonate here and useful to you. So this is ArcGIS Business Analyst. When we started working on platforms that we wanted to put all this data on, we had to recognize our user. A lot of the folks that we have out in these market are not sophisticated analysts, so we needed tools available to them that were simple and easy to use. So ESRI or ESRI, you probably saw a lot of their COVID maps. They are probably the Cadillac system of mapping systems. I do not get a kickback for talking about their product. It's just a really great tool. I've worked with it for about 20 years now. So this is our ArcGIS Business Analyst tool. This is something that you can go out and you can purchase yourself. We happen to, because of Torch being a nonprofit, we were able to qualify Torch for nonprofit pricing for all of the tools that we have available. So we got them at a significantly reduced cost, which actually made this program viable. So big shout out to Esri for helping us out with all of that, because without that, it would have been probably a much more expensive venture to put all this data together. So here we have the state of Texas, and I'm going to pull one of the data sets that David talked about. I'm going to add to my data set here. I have loaded the Medicare, what's called the geographic variation file. And I'll put a link to this file. It is a free file. It's one of the ones in that free category that David talked about. But this is actually kind of a nice little file. It talks about a lot of the metrics here for Medicare fee for service. Now, if you have a heavy Medicare Advantage state, you're probably going to have to think about how you're going to make adjustments, but at least it begins to inform some of our information. So we can see a lot of data here. There's a lot of race data. There's inpatient information. There is emergency department, outpatient. So this is one of those files you might want to go out and actually download and take a look at. It has post-acute care information. So we can look at SNF and rehab and things like that, LTAC. So I'm going to go down here because we focused a lot last summer on rural health clinics. And I'm going to pull in rural health clinic data. So there's quite a bit of rural health clinic data. I'm going to focus on the visits per 1,000 beneficiaries and add that to my map. Okay, already now Texas is a big place. So we have a lot of variation here within the state of Texas. You can probably divide this up into 6 states in and of itself. But we've got the Panhandle region, and the darker the color, the higher the use rate or utilization of rural health clinics. So already we can see the Panhandle uses rural health clinics a lot, and the East Texas area, not as much. Now we can also add in another piece of information here. And so I'm going to add in a map layer that I already have prepared that we used when we put together the rural health clinic information. And so that is, oops, wrong file, hang on. Oh, you can see how much data I have over here. Okay, so I'm going to add in the cost reports for the rural health clinics. Now it's also given me the point location for all of our rural health clinics here in Texas. And I can add a criteria here by adding that point layer. Okay, so I can add that criteria in here and it begins to be part of our model. Okay, so now it's added that layer and I can add in the visits related to the cost report information. So I'm going to summarize this and I'm going to pick total visits. Okay, so now I have got another piece of information that's helping us to inform what we're doing with those rural health clinics. Now you can continue to see, even though we're using fee for service Medicare in the rural health visits, we've added in the cost report information. So now we've added another piece of information to help inform our model. So it's building the model as I go along here in terms of what's happening. So Collingsworth, Texas, which is up here in North Texas, is one of the highest areas of rural health clinic use. So the great part about using GIS is I get the context of geography. Okay, so the next piece of information that I can add in here, show your options, is I can add another piece of information. And so as David talked about pulling in the population information, now I'm accessing ESRI's population data. So a lot of that stuff that's out there in terms of the American Community Survey that gives us behaviors such as Medicaid policy, internet access, whether or not we eat organic foods, there's a ton of information out here. So I'm actually going to pick just one metric. Remember where I put it, under health. And I'm going to look at persons with a disability. And I'm going to add that to my map. So now my colors have changed a little bit. Again, Panhandle is still dark. But see, in a couple of clicks now, I'm beginning to shape a lot of this information. Now, the other thing that I can do is I can add in, if I want to, I can go out here and I'm not going to add it right now, but I can show you I've got a lot of information. I can go down here and I can add in the Texas Department of Transportation information. And it's going to actually clutter up my maps, which is why I'm not going to add it. But that is done by another complete different department. It's out in the open use area where I can pull in that map layer and maybe look at construction zones that are happening across the state of Texas. So I can add that in if I wanted to. And then the other thing that I can do very quickly is I can add historic data, historic traffic count information. So now I'm going to go back up here to the panhandle and begin to look at, you know, corridors where people are traveling, where we have heavy traffic and cars moving along the interstates. So that may be where we want to place billboards or do some other information work to inform our decisions. Maybe instead of putting the rural health clinic way down here, maybe it's closer to the interstate with social media tags to be able to send people.
She's freezing up, and before we get too deep in the weed, I just want to. Okay. Hey, I just want to, before we get too deep in the weeds and lose y'all, we just want to demonstrate that, you know, the system is very versatile. And when we think about things like population health, which is, you know, multidimensional, very nuanced, market in some way, market specific, is to be able to access data in the right way, to really understand, you know, the dynamics in each of the areas that you're working with. And so, you know, whether it's from a population perspective, operational perspective, our thinking from the data work is, you know, structure the data in a way that busy executives and care providers are able to say, hey, of all the things that I do, you know, what are the 20% of things that generate 80% of the impact, whether that be in terms of outcomes, in terms of revenue, in terms of impact. What are 20% of what I do that have 80% of impact? And begin to look at that 20% first, right? My bread and butter. And of those things, where are the growth opportunities so I can target for growth? And where are things that I don't do well? You know, often in rural, we say, hey, we're some small volume. And so if only we just get more volume, but we've seen through the data that oftentimes there are places, plenty of places where the more you do, the more you lose. And so you got to make sure you understand where those areas are as well in order to, you know, curb costs, look at different strategies. We're actually in the process of building what we call an optimizer tool that allows you to pull the different levers in terms of volumes and pricing and even contract rates to see how you can get to desired outcome. So long story short, you know, when you look at things like population health, multidimensional, you have to have the right perspective from a data from the data use in order to look at the right thing. You know, we can't afford to just keep doing initiatives until something works out, right? We don't have the luxury of investing in different things until something works out. And so we got to make sure that the data points us to the opportunity that meets market demand. And so that's sort of our guiding principle for how we're getting engaged with our hospital and how we're driving some of the data tools to them.
Thank you.
I know that's really fast, and so I just want to make sure we don't go over too much. And if there's a minute or two for questions, we'd love to answer those.
Or go to that website. I'm telling you, this is extremely impressive in that regard. We should also mention that data set was mostly funded by the Texas Flex program. So it's something that's possible for your state as well. We have one more speaker here, Melissa Bosworth. And Melissa, I apologize because we've got so much content, but do take the time to give your full presentation. And I hope you folks are going to stick with us because this is a very impressive initiative as well.
Great, thank you. And yeah, just to confirm, I did reduce my slides down if we need to, just for time, but would you like me to go through all of them or just
go ahead. Those of us that can stay, I'm fascinated by what you're doing. Go ahead.
Melissa, I'm so sorry. Go ahead. Will you do it the way we've kind of discussed? Sure. The slides are there so they can really see a lot about what your consortium is doing and all of that. So kind of as we discussed, please.
Sounds good. And no problem. This was all really, really fascinating work. I'm happy to be here with you. And like Terry and Nicole said, the slides are available and I'm happy to talk with anybody offline. I will just start out by saying that I'm not a data guru. So actually reducing my amount of time will probably be okay. I unsuccessfully tried to already recruit Quan into Colorado, because yeah, what they're doing there is absolutely incredible. I'll say that the Eastern Plains Healthcare Consortium, we're at the beginning of our data journey. We are in the process of implementing a lot of these initiatives that that are in these slides overall, but many of you may not know who we are because actually we started in 2015. So we're kind of still in our infancy. I would say that we're a toddler a little bit, getting our legs moving overall. But with that said, we have a lot of programs already. So we participate in staff sharing, where we're sharing our nurses, and this was particularly helpful during the pandemic, and we're expanding that into services like lab, radiology, areas where we have a lot of need. All of these different areas too, data is going to be helping, and I will just say that. We have affinity groups. One is through our HRSA network development grant that we have, but we also meet with all the different C-suites, so there's a lot of organic networking. We're working on some insurance reform, and I'll touch on that because that's highly data related. CHNAs is also data related, and we help facilitate individual hospitals, but then we also have a regional set of priorities that help to develop our strategic plan. Policy and advocacy at the local, the statewide, and the federal level. Again, where data is going to be really important, that I'll talk about. And then our telehealth program. So we have a behavioral telehealth and a remote patient monitoring. And again, all the different things that come up between our hospitals. And I forgot to mention, what is the size of our consortium? We are a consortium of 10 critical access hospitals out on the Eastern Plains of Colorado, which is highly agricultural. And then we have one system member that is Banner Health System. So I'm actually going to scroll down. Again, you have the slides, and I use some acronyms, but I'm always available offline if you want to talk. Right into what we're hoping to achieve with using our data. And we went through a very large vetting process, but we decided to go with a system called I2I. It's a data platform that attaches to each of our hospitals' EMRs. And the vetting process took about a year. How we are funding this is through some rural support fund dollars that were given to each of the hospitals through our state Medicaid agency, which is Healthcare Policy and Finance. But how we intend to use this, we wanted a system that could be added on to each EMR to do automatic data reporting. You would not believe the amount. Well, I should read the room with your faces. You know that many of your quality directors or your members' quality directors are still manually pulling data from different EMRs. This will help eliminate a lot of that. We wanted data to connect across all of our 10 hospitals. Again, kind of the vision of what Torch is doing, because they're doing such incredible work. We wanted to emulate that as well. We also wanted to see how David and how Terry and Quan talked about, what about the social determinants of health, and how do those relate to the claims data and the clinical data? Not only the clinical data, but also the financial data associated with it. We are planning to use this data for longitudinal uses. So being able to look past through history and use that to inform our decisions into the future. One thing that we're really excited about is building a quasi health information exchange across our entire region. Our options in Colorado have been cumbersome. They've also been expensive sometimes to integrate, and this would allow us to be able to connect all the hospitals in a similar format that an HIE does. And then external connection. So we need to send data to a lot of different partners. This acronym here in the bottom, the RAY, that's kind of the equivalent to an accountable care organization in Colorado. And there's a lot of reporting that has to go to those for different payers, including Medicaid. So on this next slide, we are also formulating some data dashboards. Now ours do not look like Torches at all yet, or what David showed. We hope to do that in the future, but we do have some things going out, which I'll show you in just a second. We're putting these out monthly with regional quarterly review. And it's a quick dashboard so that multiple stakeholders can get information that's important to them. So the CEOs can get information on their out migration and their ED visits. The CFOs can get their claims data, and the quality directors can get the data that they need to. We are putting them out for each individual hospital, but then also looking at a regional. And we're using these decisions at the consortium level to help with our operational, the programs that I talked about, but then also to formulate our strategic direction overall. This is a little bit what our dashboard would look like for an individual hospital. It's web-based, and these acronyms on the left aren't going to mean anything to you, but they do for the hospital specifically. But it shows you very high level in an easy format where are the areas that I need to pay attention to. You can see that red and say, oof, I need to go look at that. And then when you click on that arrow on the right, it'll take you to more detail and drill it down for your hospital, but then also compare you to all of the other members within the region. And then there's also views like this, where you can see specifically on a clinical data, what do your ED visits look like? And is this trend going up or is it going down? MEUs stand for morphine equivalent units. So how are you doing on your opioid initiatives? Are you trending downwards? Are you trending up? And how do you look in comparison to a specific provider, or how do you look like in comparison to the hospital down the street too? All of this is available to our hospitals. Now, I mentioned that we are also using this for our data and insurance reform. So right now, our region has the highest premiums for community members in private insurance, but the lowest reimbursement rates for the hospitals of any other region in the state. And this is a problem, and we haven't been able to solve it with other partners, so we're creating our own solution. But that definitely requires significant data infrastructure. So where we're using this data is on these different bullets, which I'll quickly go through, not in full detail. We are using the data to look specifically at the employees within the hospitals. And this goes towards the incremental approach. We're using this first to implement an insurance plan, a self-insured plan within the hospitals, but then we're expanding it into the different large employers within those communities, mainly agricultural. We're using this data too to make it community driven, so that it's not just based upon the hospital and the reimbursement, but also getting the input from the community. And that's taking a lot into the social determinants of health data that's coming in. Transparent data, so that this data can be shared across the hospitals. We've run into a lot of pitfalls with legislation associated with antitrust, and we did put policy forward this year in our legislature. It failed. We are planning to reintroduce it next year, but we've used all the data that we've gathered to make that policy position really strong. We want to be able to keep the local care first. As we know, so many rural residents end up having to travel to the cities over and over again for care that they could be getting locally, but isn't currently paid for. So now we have the data to show that it can be provided locally and also paid for at an equitable rate. And then the centralization of care. One of our large strategic priorities is to start centralizing services within the consortium region. And that means that Hospital A may hold the behavioral health specialist and Hospital C may hold the orthopedics, and we're able to keep care in regionally instead of within the cities. And all of that requires the sophisticated data that we're building out. And so our timeline, again, we are at the beginning of our data journey. We're currently in the process of rolling out this data platform among our members and playing with the data dashboard. We have so many research questions, and we're fine-tuning what's going to be the most important to our members. And then the initial data analysis has been done with our insurance reform over. And then in 2023, we're hoping to integrate the social determinants of health with that claims data. And then we're also planning on reintroducing the legislation that we did this year that didn't pass. And then moving into the future, we're going to be taking that data decision making into further heights and launching our self-insurance model, knock on wood, if the legislation goes through. And then 25 and beyond, we're just going to continue to evolve those processes. So this was really fast, but again, my contact information is on the slides, and encourage you to reach out should you have additional interest. And thank you so much.
Melissa, thank you so much. If we're going to make a dent in the social indicators of health or population health in general, this is the stuff we're going to have to do, guys. It's like we're going to have to create this sort of a database. I think we've seen two really impressive information databases. Please let us know if you have questions about this, or if you want to ask either Melissa or Kwang or the Texas program about this as well. It's going to be imperative that we do this. So anything that our Flex programs can do to help set up similar databases and similar information systems in other parts of the country will be extremely important. Nicole, did you have any final things? I want to thank you guys, especially those of you who stuck around for the end of this. Anything, Nicole, that you want to say in closing?
Not really. Thank you, all of you, David and Melissa, Leanne, and Kwang, who had to leave. Full presentations will be available on the website in just a few days when the webinar playback is available. So I think Melissa really didn't get to do all of her presentation. I would encourage all of you that are part of Flex programs to make sure you look at her slides, because I just think that the 10 Critical Access Hospital Consortium concept is really cool, and they're doing so much together. So I would just encourage you all to take a peek at her full set of slides to see all the really cool things her consortium is doing. And then also I put in the chat to please just take a second on your way out to fill out the post-event polling questions, and that's it from us.
Thanks, everyone, and thanks for our speakers.
Yeah,
Terrific.
thanks, everybody. Have a good day.
Thank you.